Welcome to the neurology portion of the First Aid Review brought to you by Falcon Reviews. My name is Dr. Daniel Yano, and I'll be your instructor for this portion of the lecture. If you feel that more depth of coverage is needed, please refer to the Falcon online component for Step 1, Neurology. The central and peripheral nervous systems are made up of multiple cell types: neurons in both the CNS and PNS, ependymal cells, oligodendroglia, astrocytes, Schwann cells, and microglia. These cells are derived from different primordial layers and migrate to their final locations. For example, CNS neurons, ependymal cells, which make up the inner lining of ventricles and make CSF, oligodendroglia, and astrocytes are all derived from the neuroectoderm. Schwann cells and PNS neurons are derived from the neural crest, and microglia, which are the brain's version of macrophages, come from the mesoderm. We will now briefly describe each of these cell types. Neurons are what make up the nervous system. These are permanent cells that, with very few exceptions, do not divide in adulthood. Many of these cells are very large, with large nuclei and large nucleoli. Nissl substance, which corresponds to the rough endoplasmic reticulum, is present in the cell body, often called the soma, and in the proximal dendrites, but is not found in the axons. Astrocytes are an extremely important form of supportive cell in the brain. They provide physical support and repair for neurons. They soak up the excess potassium that leaks out of neurons during heavy action potential firing. They also remove excess neurotransmitters like glutamate and GABA that build up in the synaptic cleft. In addition, the footplates of the long filopodial projections of glial cells form a major part of the blood-brain barrier. Also, when the brain gets injured, one notable marker of injury easily seen with brain imaging is reactive gliosis. In addition, you should know that on neuropathology, the unique marker for these cells is glial fibrillary acidic protein, or GFAP. Microglia are part of the brain's own immune system. They are CNS phagocytes derived from the mesoderm. They are generally small cells with relatively little cytoplasm and are hard to see when doing a Nissl stain. When tissue is damaged, however, they form large amoeboid phagocytic cells. One interesting clinical correlation is that in the setting of HIV infection, HIV-infected microglia fuse to form multinucleated giant cells in the CNS. Oligodendrocytes provide myelin to neurons in the CNS. These cells have multiple projections, and therefore each cell can myelinate up to 30 different axons. On a Nissl stain, these cells are quite small, with small nuclei, dark chromatin, and little cytoplasm. You will hear people refer to gray matter versus white matter. The difference between these two is that gray matter has mostly neurons, astrocytes, and synapses, while white matter has mostly myelinated axons, and the predominant glial cell type present in the white matter are oligodendroglia. These cells are selectively destroyed in MS, and neuropathologically, they look like fried eggs. This will become very important when trying to distinguish between the different tumor types neuropathologically. Schwann cells are essentially the equivalent of oligodendrocytes, but these are in the peripheral nervous system. One major difference is that each Schwann cell innervates only one PNS axon, and that each PNS axon, which can be very long, may be myelinated by several different Schwann cells. We also know that peripheral neurons, unlike central neurons, can regenerate, and damaged axons can be regenerated with the help of Schwann cells. These cells, as mentioned previously, are derived from the neural crest. There are a few clinical correlations to these cells. These cells are destroyed probably via an autoimmune process during Guillain-Barré syndrome. In addition, acoustic neuromas are comprised of neoplastic Schwann cells and are therefore a type of schwannoma. These are typically located along cranial nerve 8 in the internal acoustic meatus. In this slide, we'll cover sensory receptors. These are the organs that transform physical pressure changes in the skin to neural impulses, and there are several types of these receptors. The simplest type is a free nerve ending. These are found primarily as endings of C fibers, which are thin, unmyelinated fibers and therefore conduct very slowly, but are also found in some A delta fibers, which have large diameters and conduct quite rapidly. These receptors are found in all types of skin, in the epidermis, and are found in some visceral organs, and these free nerve endings carry mostly pain and temperature information. Meissner's corpuscles are complicated structures. These organs transfer touch information to large, myelinated fibers and are found in glabrous or hairless skin, such as the palm of the hand. These structures encode position sense, dynamic fine touch, for example, when you are manipulating an object in your hand, and generally adapt quickly, which means that they will respond at the onset of a stimulus, then quickly turn off. Pacinian corpuscles transfer touch information to large, myelinated fibers, but these are in the deep skin layers, ligaments, and joints. These carry vibration and pressure information. Finally, Merkel's discs, which also send information to large, myelinated fibers, are found at the base of the hair follicles. These fibers carry information about position sense and static touch, for example, shapes, edges, and textures. Unlike Meissner's corpuscles, axons carrying information from Merkel's discs will adapt slowly. That is, they will fire action potentials throughout a sensory stimulus. This slide illustrates the structures in a peripheral nerve. Peripheral nerve contains axons, Schwann cells, and multiple types of supportive connective tissue. For example, the endoneurium is the connective tissue that invests single nerve fibers, and this is where inflammatory infiltrates are found in Guillain-Barré syndrome. The perineurium surrounds fascicles and provides the permeability barrier for axons. For this reason, the perineurium must be rejoined during microsurgery for limb reattachment. The epineurium is the dense connective tissue that surrounds the entire nerve, including both fascicles and blood vessels. One way to help remember these is that the prefix endo usually means inner, peri usually means around, and epi usually means outer. Moving on to neurotransmitters. There are many different neurotransmitters, and we will review a few of them here. One example is norepinephrine, whose levels are high in anxiety, low in depression, and one major site of the cell bodies responsible for the synthesis of norepinephrine is the locus ceruleus in the brainstem. Dopamine is thought to be abnormally high in schizophrenia, low in Parkinson's disease and depression, and the primary sites of the cell bodies of the cells that make dopamine are the ventral tegmental area and the substantia nigra pars compacta. Serotonin is a clinically important neurotransmitter whose levels are probably low in anxiety and depression. The cell bodies for many of the cells responsible for serotonin production are in the raphe nucleus in the brainstem. Acetylcholine levels are low in Alzheimer's disease and altered in Huntington's disease and during REM sleep. One major source of cholinergic neurons is the basal nucleus of Meinert in the basal forebrain. GABA, which usually functions as an inhibitory neurotransmitter, is found in lower than normal levels in anxiety and in Huntington's disease. There are many sources of GABA in the brain, and one of them is the nucleus accumbens. One way to distill down what some of these nuclei do is that the locus ceruleus is important for stress and panic responses, while the nucleus accumbens and the septal nuclei are reward centers, responsible for pleasure, addiction, and in some cases, fear. One important concept in clinical neuroscience is that of the blood-brain barrier. It has a complex overall organization formed by three structures. Number one, tight junctions between non-fenestrated capillary endothelial cells. Number two, the basement membrane. And number three, astrocytic foot processes. For substances that need to cross this barrier, like glucose and amino acids, they can be transported by various transporters. Lipid-soluble substances just get into the brain by diffusion. There are several places in the brain where the blood-brain barrier is less restrictive. Number one, the area postrema. The neurons in this area can sample toxins in the blood and therefore can trigger vomiting after things like chemotherapy. Number two, the OVLT, or the organum vasculosum of the lamina terminalis, which contains osmoreceptors. Number three, the posterior pituitary, or the neurohypophysis, which releases its products like ADH into the bloodstream. Similar barriers exist in other parts of the body, for example, the blood-testis barrier and the maternal-fetal blood barrier of the placenta. Pathologically, the blood-brain barrier breaks down during things like infarction or infection, leading to edema. We will now go through several brain structures. We'll begin with the hypothalamus, which has many functions, and one way to remember these functions is to use the mnemonic TAN hats. 1. Thirst and water balance. 2. Adenohypophysis control. 3. Neurohypophysis releases hormones from the hypothalamus. 4. Hunger. 5. Autonomic regulation. 6. Temperature regulation. And 7. Sexual urges. The hypothalamus gets inputs from the OVLT, the area postrema, and multiple other areas. There are multiple subnuclei in the hypothalamus, including 1. The lateral area, which is important for hunger. Therefore, destruction of this area will cause anorexia and failure to thrive. One mnemonic for this is that if you zap your lateral nucleus, you'll shrink laterally. The ventral medial area, in contrast, is for satiety. Destruction, as in the case of a craniopharyngioma of this area, will cause hyperphagia. This can be stimulated by leptin. A mnemonic for this is that if you zap your VM nucleus, you will grow ventrally and medially. The anterior nucleus is for cooling and parasympathetic control. Think of AC as cooling for your mnemonic. The posterior hypothalamus is for heating and sympathetic control. Think of the posterior nucleus as getting fired up, so if you zap your posterior hypothalamus, you become a poikilotherm, cold-blooded like a snake. The septal nucleus is for sexual urges, and the suprachiasmatic nucleus, or the SCN, is for circadian rhythms. To remember this, remember that you need to sleep to become charismatic. Thankfully, the posterior pituitary is much simpler than the anterior pituitary. The posterior pituitary gets its inputs from the supraoptic nucleus to drive ADH production and release from the paraventricular nucleus to drive oxytocin production and release. Think oxy comes from oxys, which means quick, and tocin comes from tokos, which means birth. Recall that these structures are distinct from the adenohypophysis, which is the anterior pituitary. Sitting above the hypothalamus is a large gray matter structure known as the thalamus. It is the major relay for ascending sensory information that reaches the cortex and is divided into multiple smaller subnuclei, each of which are involved in a particular sensory, motor, or cognitive role. For example, the lateral geniculate nucleus carries visual information and sends projections via the optic radiations to the occipital cortex. You can remember this because the L in LGN stands for the word light. The medial geniculate nucleus carries auditory information to the temporal cortex. You can remember this because the M in MGN stands for music. The ventral posterior lateral nucleus carries somatosensory information from the body, excluding the face, to the sensory cortex. The ventral posterior medial nucleus carries somatosensory information from the face via cranial nerve 5 to the somatosensory cortex. This can be remembered by the mnemonic that M is for makeup that is put on the face. The ventral anterior and ventral lateral nuclei carry motor information to the motor cortex. The blood supply to the thalamus comes from several sources: the posterior communicating artery, the posterior cerebral artery, and the anterior choroidal branches from the internal carotid artery. The limbic system is a series of nuclei comprising the cingulate gyrus, hippocampus, mammillary bodies, and other regions like the septum. These regions are responsible for the essential functions for the survival of the species. These are the famous 5 F's: feeding, fleeing, fighting, feeling, and sex. The cerebellum is a critical structure for motor control. it receives contralateral cortical input from the middle cerebellar peduncle and ipsilateral proprioceptive information from the inferior cerebellar peduncle. These inputs come from climbing and mossy fibers. The role of the cerebellum is to provide feedback to the contralateral motor cortex to modulate movement. The outputs come from the Purkinje cells sitting in the cerebellar cortex, which synapse on the deep nuclei of the cerebellum, which sends outputs to the motor cortex via the superior cerebellar peduncle. There are 4 sets of cerebellar nuclei. Going from lateral to medial, they are the dentate, emboliform, globose, and fastigial. These can be memorized by using the mnemonic, "Don't eat greasy foods." The lateral nuclei control movement in the extremities, while the medial nuclei control axial muscles that are involved in balance and truncal coordination. The clinical correlate of this is that patients with midline lesions, like those seen in alcoholics, tend to have more axial than appendicular problems. Patients who have lesions to the cerebellum tend to have ataxia and fall toward the injured side of the cerebellum. The basal ganglia. The basal ganglia are a series of subcortical nuclei that are important for control of movement and for making postural adjustments. The basal ganglia receive input from all areas of the cortex and ultimately send feedback back to the cortex to modulate movement. The basal ganglia network is shown here, with light-colored arrows being excitatory and dark-colored arrows being inhibitory. The input station of the basal ganglia is the striatum, which is comprised of 2 nuclei, the caudate, which is primarily involved in cognitive function, and the putamen, which is primarily motor. Input from the cortex is excitatory, and there are 2 inputs from the substantia nigra pars compacta. One input synapses on D1 receptors, and the other is inhibitory in synapses on D2 receptors. There are 2 types of neurons in the striatum: intrinsic cholinergic neurons, which are excitatory, and GABAergic inhibitory projection neurons. Some of these neurons contain substance P and project to the globus pallidus internal portion as well as the substantia nigra pars reticulata, while the other projection neurons contain enkephalins and project to the globus pallidus external portion. The globus pallidus external portion then sends GABAergic inhibitory neurons to the subthalamic nucleus, which sends excitatory glutamatergic projections to the globus pallidus internal portion. Both pathways, the direct, shown on the left, and the indirect, shown on the right, end at the level of the thalamus, which is inhibited by the GABAergic projections from the globus pallidus internal segment. The thalamus then sends excitatory input to the cortex. Under normal conditions, namely when dopamine levels are present in normal amounts, the thalamic neurons do not receive substantial inhibition. When dopamine levels are low, the direct pathway more actively inhibits the thalamus, and the indirect pathway is less able to activate the thalamus. Therefore, motor output decreases. So then there are 2 pathways: an excitatory, sometimes called direct pathway, which increases motor output. When dopamine levels are low, as in Parkinson's disease, this pathway is less active because of less D1 signaling. Then there is an inhibitory, sometimes called indirect pathway, which decreases motor output. When dopamine levels are low, as in Parkinson's disease, this pathway cannot drive D2 receptors, and there is less motor output. This concludes the first portion of the First Aid Neurology Review brought to you by Falcon Reviews.